Ladies and gentlemen, good afternoon. I'm Dr. Junwen Ou from Clifford Hospital, Guangzhou, China. Today, I will go through my presentation with intravenous vitamin C synergy with MEHT significantly improved prognosis in advanced non-small cell lung cancer patients. Lung cancer is the most common cancer type in China, accounting for 20% of all newly diagnosed cancer cases. Although there are many kinds of treatments, the results were discouraging. Vitamin C infusion and modulated electrohypothermia are widely used by integrative cancer practitioners for many years. However, there are no safety and cancer response data in Chinese non-small cell lung cancer patients. Today, I would like to share the research data from Clifford Hospital. First of all, I will go through the history of anti-cancer aspects of vitamin C. Vitamin C has controversial history in cancer treatment. In 1976, Pauling and Cameron performed clinical trials giving patients 10 gram intravenous vitamin C and 10 gram orally vitamin C. The results show that vitamin C can significantly prolong overall survival time of terminal cancer patients, which including colon, stomach, breast, lung, kidney, bladder, and ovary cancer. However, they were heavily criticized after subsequent double-blind and placebo-controlled trials using oral vitamin C at the Mayo Clinic, failing to show any benefit. It was recognized later that the route of vitamin C administration was the key reason for the discrepancy. The originally reported studies using intravenous vitamin C produces much higher plasma concentrations than the subsequent trials employing oral vitamin C. More recently, Dr. Chen had revealed that vitamin C at pharmacological concentrations achieved only by intravenously administration. It selectively kills a variety of cancer cell lines in vitro, but has little cytotoxic effect on normal cells. Furthermore, high-dose parenteral vitamin C administration represses the growth of numerous cancers in xenografts models. A pilot phase 1 and 2 clinical trial was conducted in patients with newly diagnosed stage 3 or 4 ovarian cancer. High-dose intravenous vitamin C was added to conventional paclitaxel carboplatin therapy. 27 participants were randomized into either the standard DP and PAX arm or the CP and PAX and ascorbic acid arm. The results show that vitamin C can significantly reduce the toxicity from chemotherapy. In comparison with the chemotherapy, progression-free survival was 8 months longer in the combination arm. Therefore, BBC News comments that vitamin C gives chemotherapy a boost. When we search from clinical trial website, we can find out there are dozens of clinical trials ongoing, and it covers nearly all types of cancer. Our research team registered a phase 1 and phase 2 clinical trial to evaluate the safety and efficiency of high-dose IVC synergy with MEHT in patients with advanced NSCLC in 2016. In phase 1 clinical trial, the primary endpoint of the treatment trial was to evaluate the safety, tolerability, and pharmacokinetics of high-dose intravenous vitamin C synergies with MEHT for patients with stage 3 to 4 NSCLC. The second endpoint of the study was to find out whether there is a relationship between fasting blood vitamin C and degree of tumor burden in NSCLC patients. Based on previous studies in the interaction of heat with different kinds of drugs and different drug heat sequence can achieve different clinical results. However, there is no relevant research study for the interaction effect of heat with intravenous vitamin C. Thus, the third endpoint was to identify the best pattern and sequence of intravenous vitamin C synergies with MEHT for the preparation of a phase 2 study. Participants were randomized into 3 groups. Group A received IVC when MEHT was finished. Participants in Group B had IVC administered simultaneously with MEHT, and in Group C, IVC was applied first, followed with MEHT. In Group A and Group C, MEHT was applied in conjunction with IVC within 5 minutes interval of time. The power of MEHT was gradually increased from 135 to 150, depending on the patient's actual tolerance. The patient was lying in prone position and the treatment covered the complete lung. The temperature of treatment area is about 40 to 42 centigrade indirectly calculated by the treatment device. The process was applied 25 sessions with 3 times a week, every other day, weekend days off, for 2 hours per session. We found that fasting plasma ascorbic acid was significantly correlated with the stage of disease. The lower the level of plasma vitamin C, the more advanced stage of the disease. In comparison with healthy people, fasting plasma vitamin C was significantly lower in stage 3 to 4 NSCLC patients. Among the 3 groups, peak concentration of vitamin C was significantly higher in Group B than in the other 2 groups, while other vitamin C concentration time profiles showed no significant difference between the 3 groups. This may be due to localized heat improving the circulation of the medication. Similar definite, significant increases of Cmax were observed by MEHT in the study of nefapin. The overall toxicity was marginal. Thirstiness was the major symptom during all of the treatments, and this was observed in both the IVC and combined treatment groups. Symptoms disappeared when the treatments were finished, except for 1 patient experienced serious diarrhea. This patient was withdrawn from the study in the stage when he finished the second combined treatment at a dosage of IVC 1.5 grams per kilogram. In conclusion, our phase 1 clinical trial proved that IVC simultaneously with MEHT are safe and well tolerated for advanced non-small cell lung cancer patients. This motivated us to carry out a phase 2 study by administering MEHT simultaneously with IVC, which can produce higher peak concentration of vitamin C in plasma. In our phase 2 study, we assessed for 137 NSCLC patients. 97 patients met the inclusion criteria, and they were randomized into supportive care arm and IVC plus MEHT plus supportive care arm, which can call it the combination arm. The baseline patient characteristics have no differences between 2 arms. When patients finish 25 sections of the combination treatment, we examined the inflammation profile, which include interleukin-6, CRP, and tumor TNF-alpha. We noticed that interleukin-6 and CRP levels significantly decreased after treatments in the combination group, also significantly lower than in the control group. However, we did not find any changes on TNF-alpha. We suspected that IVC plus MEHT can improve outcomes for advanced NSCLC patients through modulating cancer inflammatory microenvironment. The adverse events were similar to phase 1 clinical trial, which was very mild reactions. And we found that the combination treatment can significantly improve the overall functional status and can significantly alleviate different kinds of symptoms in comparison with the control arm. 3-month disease control rate was defined as the percentage of subjects with complete response, partial response, or stable disease at 3 months relative to all randomly assigned patients. In this study, 3-month DCR was 46.7% with combination therapy, significantly higher than with supportive care alone, only 17%. The median progression-free survival for the combination arm and control arm were 3 months versus 2 months, which was significantly longer than in the control arm. And the OS was 12 months and 8 months in the combination arm and control arm respectively. The combination treatment can significantly prolong PFS and OS in advanced NSCLC patients. However, when we compare different IVC dosage on 3 months DCR, PFS, and OS, we did not find any differences in DCR, PFS, and OS between 3 dosage vitamin C groups. And we did not find any difference between adenocarcinoma and squamous cell carcinoma for 3-month DCR, PFS, and OS. And these 3 cases are our very successfully treated cancer patients. So in conclusion, our phase 2 clinical trial suggested that IVC plus MEHT can significantly improve quality of life, can significantly prolong PFS and OS, can significantly modulate cancer-related inflammation, which are beneficial for advanced NSCLC patients. The underlying mechanism might be due to group 1 overexpression in lung cancer cells, which enhance the sensitivity of lung cancer cells to pharmacological vitamin C. High-dose vitamin C significantly induced ROS elevation via depletion of the antioxidant glutathione and suppressed growth of lung cancer cells. Now we are conducting the mechanism study in vitro and in vivo. Hopefully we can get the rough results at the end of November this year. So in the future, we will continuously to investigate whether these combination treatments can prolong time of resistance to targeted therapies, or whether they can enhance the efficiency of immunotherapy. Thank you very much for listening. Bye-bye.